Head injuries. So this will run quicker because you already understand the concept of CPP and you understand why we want the blood pressure to be high, correct? Whenever someone has an increased intracranial pressure. Okay, so increased ICP are present again, not only in head injury patients, but also in stroke patients, both ischemic and hemorrhagic stroke, especially in hemorrhagic stroke. So head injury is it also could be called traumatic brain injury. So you're not aware, but there are actually more head injury cases than you would like to think. So most accidents end up with a head injury. So not only that, we have our military people suffering head injuries as well. Okay, so it's both traumatic. There are also non-traumatic head injuries that could occur. Not only car accidents, but falls, for instance, like children fall, right? Babies fall. We have accidents like that. Most cases, though, still involve the elderly. We do have, you may think, oh, it's younger people that get into accidents. No, actually, it's the older people. Okay, still highest on, you can look at the National Highway Traffic Safety website. They show statistics there. It's really the elderly that get the most car accidents. Okay, so here's the prevention part. This will answer chart 63-1. This will help answer questions on how you prevent head injuries. So not only these, but we also have professional sports, right? Not even professional sports. We have non-professional, let's say high school athletics as well. They suffer head injuries as well. If you ride a motorcycle, so the best thing here is to wear a helmet. Okay, so if you drive a car, put on your seatbelt. All right. So I kind of discussed this earlier, and we actually went through some of the 6 secondary injuries already, but let's repeat it here. So when someone suffers from a TBI, sustains a TBI, there are 2 sets of problems here. One is the primary injury. What is the primary injury? This is the actual consequence of the direct contact to the brain or head. So there are compartments in the body. We have, you've discussed compartment syndrome previously, right? Probably in MedSurg 1. Okay, so this is the most rigid compartment in the body, the skull. So in a grown person, the skull is the most rigid compartment in the body. This doesn't apply in the infant because the infant has a very pliable skull, right? It's soft, they have open fontanelles, suture lines are still open, they're not fused yet. So they have some room for increased ICP. Okay, so there's some give to it. But in a grown person, everything's closed. So it becomes a compartment. So primary injury, again, these are the contusions, lacerations, hematomas, and fractures that result directly from the cause of the primary injury. Now, the patient's problems do not end there because for the next succeeding hours, the next 24 to 48 hours, 6 secondary injuries will develop. So let's go to the 6 secondary injuries now. So they are, as mentioned in the previous page, one example is intracranial hemorrhage. So that's bleeding into the skull. There's edema. There's increased intracranial hypertension. There's hyperemia, seizures, vasospasm. And then there's the hydrocephalus, the bleeding and the hematoma, etc. And remember I showed you the bottle earlier and also talked about a glass of water, right? Okay, so that concept is known as the Monro-Kelly hypothesis, or also called Monro-Kelly doctrine. It simply says that because there are 3 components in the brain, blood, and CSF, it's already 100%, correct? So the doctrine simply says, if there's an increase in one or more component volumes, meaning let's say after head injury, will the brain swell? Yes. Will there be bleeding? As a result of that, can there be herniation of the, and then displacement of the ventricles of the brain? Okay, so it's as simple as that. The head injury results in an increase in one or more of the three components. So if it's already 100% status quo in your skull, 80% is occupied by the brain, 10% occupied by the blood, 10% occupied by the CSF, that's 100. So can you increase the volume and the space to 101 or more? Can't be. It's already 100%, right? So therefore, if any increase in one or more of the components happen, then something has to be displaced, correct? Just like the cup of water, you put one more drop, something has to spill out, correct? And what is that again? We concluded this morning, what will spill out? The brainstem. Plus, of course, you know already what's happening inside. There will be some lateral and uncal or upward or downward herniation inside the brain as well. So besides the brainstem being pushed out, there's also herniation inside, which will cause hydrocephalus. Okay. These are some mild scalp injuries. Scalp injuries are very bloody injuries. The scalp is very vascular, it turns out. I suffered a scalp injury one time. I was sneaking into public school and there were barbed wires, and then I was careful with the bottom barbed wires. I stepped on it, but then forgot there's one right here on my forehead. So I got hit, ow, and then I just kept running, on with the fun. And then little did I know that I was already bleeding. And next thing my friend said was, look at you. I mean, how do I look at myself? How do I look at myself? Okay, but I was bleeding. I was covered in blood. That's how vascular our scalp turns out is. Okay, so I ran at home and then of course received a lot of spanking besides looking like I was being butchered. Okay, didn't get any sympathy from my mom. Okay, what were you doing in that sticking into the school anyway? And then there's scalp fractures. So fractures, you've read about fractures in MedSearch 1, so they can be simple or comminuted or displaced fractures, no different. So manifestations really depends. What kind of injury did you sustain? Let's name a few. So especially in the elderly, so any injury to the head usually results in these manifestations. So let's say any injury above the ear. Okay, so we call that the supratentorial. So at the level of our ear here, we have a spine in the skull which separates the upper from the lower parts of the brain. We call that the tentorium. So any supratentorial injuries usually result in a black eye. So you'll have raccoon eyes. There'll be a hematoma, bruising formation around the eyeball. So we call that, of course, the raccoon eyes, right? So anything below, such as basal fractures, will cause a battle sign. There will be a bruising behind your ear. We call that a battle sign. That's basal skull fracture. Then we can also have CSF leaking. So if there's a displaced fracture in your skull and then CSF can start to leak, they can come out of your nose or your ears. How do we test it again? We discussed this when we did the hypophycectomy. How do you know that what's coming out of your ears or nose is containing CSF? You remember? Remember the halo sign? Yes or no?
The halo sign?
Yeah, what is the halo sign again? Okay, so if we haven't discussed that, okay, so you grab a piece of gauze, any clean gauze, you dab the secretion, and then if there's a yellow ring that appears around the secretion, that indicates the presence of cerebrospinal fluid. Okay, Now, will the drainage necessarily be all clear, or is it going to be bloody? Of course, it's going to be bloody. Makes no difference if you dab the bloody drainage. So there'll be a blood spatter in the center, right? Around the blood, there will still appear a yellow ring. We call that the halo sign, and that is positive CSF. Now, why can't we just, because CSF contains sugar, correct? Why can't we just test it for sugar? Well, the problem there is the drainage really all clear, or is it bloody? It's bloody. And does blood contain sugar? So is it a definitive test to test it for sugar? No, but the halo sign, nothing else will appear like that except CSF. Are we clear? So anyone coming in with head injury, what do we do first when they come in the ER? What's the first test that's going to be done? Granting you already did ABC, we did the collar, okay, CAT scan or MRI. Same thing, no different from the stroke. All right, so brain injuries can be penetrating or blunt force injuries. Here are some minor ones. Contusion is a bruising and actual damage to the brain tissue. So the brain tissue was bruised, for instance, it sustained blunt force or penetrating trauma. So it's injured. We call that a contusion. Intracranial hemorrhage. So this is, of course, a hematoma, okay, bleeding inside a closed space. That's going to form a hematoma. Now, it will not matter because there are many layers in the meninges, correct? Okay, so we have the dura. So it can either occur right below the dura, which is subdural, or let's say above the dura, epidural, subdural, and then we have subarachnoid space, correct? And before we get to the brain tissue. Regardless of the location of the hematoma, is it a space-occupying mass? Yes. Will it increase ICP? Yes. So would not matter, just like I said, epidural. Here are the different locations. So it will not matter whether the hematomas in the epidural layer or the subdural layer or intracerebral. All of them will cause increased ICP because they will cause shifting or they will herniate brain tissue and then cause one of 6 secondary injuries. What's the earliest sign again of increased ICP? Changes in the LOC, okay? Mental status changes in the level of consciousness. And as we already discussed under hemorrhagic stroke, so most management will be surgical management, right? Open the scalp the skull and then remove the hematoma. Or if the bleeding is active, then the doctor may leave a drain, okay, to allow us to close the incision and then continue draining the secretions or the blood. If you ever end up in a nursing home, so this section here talks about subdural hematomas. Now, the problem with subdural hematomas is depending on if it's acute or chronic, what makes it acute is it's usually involving an artery busted. Okay, let's say common scenario is your resident in the nursing home got up, fell, hit their head. Because these guys talk to each other, and most probably the resident already has a previous history of a fall, and they remember what happened when they got to the ER. They waited hours. They lay down in the stretcher, for hours at a time before they even got to the CAT scan. And then after the CAT scan, another few hours before a doctor talked to them. I mean, it's an ER after all. It's busy, okay? Doctors have to prioritize which patient to see first. So after they fall, what do you think? And then nobody saw them fall. What do you think they will tell you? Or, yes, let's say they're on the ground, so they can't deny they fell. They couldn't get up, so yeah, I fell. But then they did not hit their head, okay? Because they don't want to go to the ER and go through the whole thing, okay? They said, I mean, why would I waste hours? Okay, so they'll just say, I did not. They'll swear on the Bible. I did not hit my head at all. Then next thing you know, over the next 24 to 48 hours, as those 6 secondary injuries develop, then you see increased intracranial pressure, and then you'll see changes in level of consciousness. And who's going to be blamed for this? You are, because you didn't do your job, right? You took the patient's word for it. You and the patient, are, what is that? Conspirators of a crime. Okay, so you conspired with the patient to hide an event, right? And then can that become a crime now? Yes, because especially if someone dies, right? Okay. So the patient might be lucky they're dead, but you're still alive. You still have to do time. Correct? Okay. So acute subdural hematoma, the good thing, I mean, I'm not saying this is good, but the good thing is the manifestations occur right away. So you see it, you see the mental status change. So we tend to address the problem right away. Send the patient, call 911, send the patient off. The problem is with chronic subdural hematomas, because this is like a drip. Okay, a slow drip of bleeding, a slow chronic bleed. And then by the time the patient manifests symptoms, what can be done? It's usually too late because the hematoma is so large now that it's very hard to control. So this can, look at the range, can be 3 weeks to months before the patient even manifests symptoms. Okay, this usually involves a vein or a small capillary, right? And then the patient's on aspirin, for instance, or clopidogrel. So of course, it won't stop bleeding, okay? So here are the hemorrhage and hematoma. So these are similar to what we discussed under hemorrhagic stroke. So same problems, AVM, severe hypertension, aneurysms. So that's for the contusion. Now concussion. Now there are 3 types of traumatic brain injury. We got mild, moderate, and severe. Concussion falls under mild traumatic brain injury. Now you've seen professional sports and you've seen people, athletes fall, right? So you've seen these young people fall, take a hard fall, right? No matter what sport, basketball, soccer, or football, for instance. Okay, so they all suffer or sustain head injuries. When they say a concussion protocol is started, what happens to the athlete? They're not allowed to play, correct? And they are, let's say it's not professional sports. So let's say you're placed on a concussion protocol. The reason why the patient is discharged from the ER with mild traumatic brain injury is they do not meet inpatient criteria. Because look at the manifestations of mild TBI. I'm sure there's a list. Okay, here. So these are the manifestations. Although this statement is, let me just clarify this statement. So the patient is, here's what I'm talking about. The patient is discharged from the hospital or ED because again, they do not meet the inpatient criteria. The symptoms are mild. All they're complaining about is a headache, which is expected because you just hit your head. have a headache, they feel dizzy, for instance, and that's about it. However, remember there are 6 secondary injuries that will develop. Okay, so they do not appear until 24 to 48 hours after the primary injury. So therefore, can we keep you in the ER? No. You'll be discharged home with specific instructions though, which are the following. So if the patient is discharged, they're told to call the doctor or 911 or bring the patient back to the ER if the following appear, namely decreasing level of consciousness, worsening headache, dizziness, seizures, pupillary changes, vomiting, irritability, slurred speech, or numbness or weakness in arms or legs. Because are these still mild?
No.
These are now moderate to severe TBI. Yes, sir.
How long till a mild contusion heals?
Contusion, well, depends because look at brain tissue. What color is it? White, right? Although the brain tissue we see are either cooked already or dead, right? So they appear like that. But in a living brain tissue, it's actually quite pink. Okay, it's not red, not like our mouth, which is very vascular, very red. So that means, is brain tissue really that vascular? No. So since it's not very vascular, you think it will heal that? No. So I don't know how to answer.
Put some in place.
Yeah, it'll be weeks to months. Okay.
So that's why they say don't let like the child go to sleep. Because you
That's
won't
not
sleep.
really true.
Oh, okay.
Yeah, I don't know who came up with that, but
But would it be because you won't be able to see if they're asleep, you won't be able to see if they're like progressing?
that's during only the first few acute hours though. I mean, the child has to sleep eventually. I mean, he's a child. No, they're supposed to sleep. Okay.
You know,
I mean, how do you even keep them awake? What are you gonna do? Slap them constantly? You know what I mean?
Yeah.
Yeah, it's not really accurate. Okay. There are 2 acute injuries as well. So it's either diffuse or focal injuries. Diffuse meaning it's the entire brain tissue that is swollen, that is irritated, inflamed, versus if it's focal, right here, focal lesion, that means only one section of the brain, okay, is involved. Whereas if it's diffuse, then it's the entire thing. Let's go to management now. So CAT scan, MRI, no different from stroke for us to see if there's ever anything, that they need to investigate further. The radiologist will say so on the CAT scan. So let's say the radiologist says, oh, there's a area which resembles or could be like this, and then they'll say, recommend MRI for further evaluation. And the doctor has no choice. The neurologist has to follow the the radiologist, because otherwise, if something happens to the patient, then whose ass is it? The neurologist, right? Because they didn't follow the radiologist recommendation. Okay, let's go to management. Increase ICP. So we already looked at these. How many bullets did we have on the previous page? It was a lot, right? From positioning to, I started with oxygenation, and then positioning, then temperature. What else? The drug, yeah, etc. Right? We had them, so it'll be repeated here. Remember the drainage? What device was inserted? Intraventricular catheter, right? What are the 2 purposes of the catheter again? To monitor ICP and also right here, ion and drain CSF. Okay. There are many choices actually, not just the intraventricular catheter. We've got screws, bolts, which can do the same thing. But the most commonly used is the IVC, the intraventricular catheter, because it has a serves two purposes. The others simply measure ICP. I mean, what's the good in that, right? If you can't do anything else to lower ICP. So among the other methods, it's really the intraventricular catheter that is most commonly inserted. So these are the other managements that can be used to maintain oxygen. We intubate and put the patient on a ventilator, seizure precautions, fluid again to remember blood pressure. What's the blood pressure goal here for head injury patients? Okay, again, high, right? So we want it at least 140 or higher systolic or 90 or higher diastolic. As long as it's under what? 185 over 110. Sometimes it's necessary to put the patient into a barbiturate-induced coma. Now we'll give them phenobarbital, for instance, to induce a coma, especially in severe TBI. The reason is, what happens to oxygen demand in a head injury patient? It's going to be high. Can we meet that when there's increased ICP? No. So better to decrease the demand, induce a coma. So patient brain activity drops, they're relaxed, they can heal faster. Okay. Again, this is a resort we have to go to if the patient's ICP cannot be controlled. Most severe TBI patients die within 48 hours of admission. Nothing we can do there. But moderate TBI, they have a chance, okay, of recovering. So the benzos we use besides phenobarbital are lorazepam, midazolam, or propofol. Okay, we sedate the patient. And of course, whenever we sedate somebody, we also give them opioids? Yes. Okay, we assume they're in pain, so not just sedatives, but we give them opioids at the same time. Pain is always assumed in unconscious patients. Nasogastric tube in case we suspect or there's evidence of bleeding. I won't test brain death because our role here is just to follow the doctor's order. We don't really determine brain death ourselves. So we'll skip that. We already finished Glasgow Coma Scale, so this one thing we got out of the way already. Okay, so these are the effects by system on increased ICP after TBI. So level of consciousness will suffer. It'll be, just keep in mind, if the Glasgow Coma Scale score is 8 or below, the patient will be intubated. Okay, there's no question. There's no debate. If the score is 8 or below, automatically intubate the patient. Because they can't support, I mean, at 8, that means, the Glasgow Coma Scale, right? So let's say they score a total of 8. That means, what is their eye opening? Let's say to pain, verbal response. Are they still conscious talking? No, they're probably at a 3 or a 2, right? That's already 5. And then motor response, are they able to follow commands? No, they're probably in, either the corticate or the cerebral, okay, at 8. So intubate, okay? They're pretty much in a coma. And they won't be able to protect their airway. Okay, you lower their head, you're gonna aspirate. So here are the system by system. Again, always remember increased ICP. That's what the patient's brain is experiencing. There's increased ICP there because of the 6 secondary injuries that occur. So there will be respiratory rate, changes, it'll drop, and then the pattern also will be irregular. So they can have apnea with periods of hyperventilation, very irregular respiratory rate. So that's another reason why we intubate, to make sure oxygenation is maintained. Heart, although the heart is independent of the brain, but it can still be influenced by head injury. So the patient may develop arrhythmias just the same. And remember, diabetes insipidus and SIADH. Okay, I mentioned this earlier, right? Okay, so watch the patient for these. How would you know again that the patient is in diabetes insipidus? What happens to urine output? Increases. What about SIADH? Okay. Okay, GI, the patient automatically is NPO because is there peristalsis here? Not likely. That's why we insert an NG2. Okay, so to decompress the stomach, because otherwise you'll have gastric distension and then the patient will be induced to vomit. And again, they can't protect their airway. That's a guaranteed aspiration. We start feeding the patient. What happens to the metabolic rate of this patient who has injury, who is sick? It actually increases. Okay, so the patient is fed as soon as possible. GU, this patient is going to be incontinent. The doctor will have to decide whether he wants a Foley or not. If they suspect DI or SIADH, then the patient will have a Foley catheter. Or at least you've seen non-invasive external catheters, right? Being used now, the PureWick system.
Yeah.
HAC hospitals have PureWick. Okay, so that's a better alternative to the catheter. But again, if this patient is not stable, though, let's say hemodynamically, blood pressures are concerning. I mean, how do you can a PureWick system give you hourly urine output? No, then we have to put in a Foley. Okay, but only for really unstable patients. Otherwise stable, then use the PureWick. Musculus, yes.
For men, would they recommend the condom catheter?
Yeah,
for
PureWick
men,
has a male option.
Oh,
Yeah.
I've seen that.
Yeah, it's like a big condom. Just put and then it still tapes to the hypogastric area. And yeah, it still sucks the thing. It's not really a condom because a condom is a tight fit, right?
Yeah.
The PureWick system is loose. Huh?
There's a male one.
There's a male one.
Looks like a
Yeah,
light bulb.
they have a male.
Like a light bulb.
Yeah, the female is the foam. But
Yeah.
obviously, the male is not a foam. It's just a regular plastic. Okay. Yeah, because otherwise it'll be, discriminatory, right? If PureWick only makes one for females, and then males will say, well, what am I, Al Qaeda? You're not gonna give one for me? Musculoskeletal system. So these patients are bedbound. So make sure you take care both the muscle and the skin. Please prevent skin breakdown and prevent muscle atrophy. Because this is going to be a long road. These patients, let's say they survive somehow, it'll be a long months or if not years to rehab them. Because they'll have to relearn everything. They'll have to learn how to speak, how to hold a spoon, how to even hold their head up. Okay. Have you ever been in 7th floor on TBI floor of Bellevue? Okay, if you get a chance, ask your instructor, drop by, see. So that's the TBI rehab unit. So you'll see patients go in there. Initially, when they go in, they're wearing a helmet and they can't even hold their head up. Yeah, they're just like this. Yeah. Yeah, and then we have to, they're a full transfer. A complete transfer, and then just give them 2 weeks. Okay, you visit that patient 2 weeks later, they can get up, they can feed themselves, they can wheel themselves in a wheelchair. Amazing therapy, but the therapy is extensive though. They do it 3-4 times a day. Okay, so very expensive. You can imagine like how many people, how many hours that is, and PT is expensive. Okay, that's PTOT, but it's very, very effective. Imagine when I see those patients come in, there's no way this patient's gonna recover. That's automatically what I say. Then 2 weeks later, oh my God, what happened? Okay, now patients talking. I mean, they're not talking like this, but they're, hey, how are you? They can talk now. They can tell you, they can communicate with you. So skin, protect the skin from breakdown, and then emotional support, very important. So here are the priorities, of course, airway and breathing circulation, neurologic function. We'll discuss all the airway stuff next week when we get to gas exchange problems. And again, what's the earliest manifestation for any change? Okay, the level of consciousness. Let me just discuss what to report, okay? So the change in the Glasgow Coma Scale score is significant if there's a 2 or more change, either a drop or an increase in the Glasgow Coma scale score of 2 is reportable. Between improvement and deterioration, which is more reportable? Deterioration, of course, right? Naturally. Improvement, yeah, you want to report that, but that's a good news report. So maybe, we don't have to like rush right now to report. But any deterioration, report it right away because it requires a change in the therapy. Maybe we need another dose of mannitol, for instance, okay, something like that. Some life-saving measure. Because any deterioration, that means what happened to the ICP? It increased. And do we need additional therapy to decrease that?
Yeah.
Yes. So this will be repeated. It has been repeated already several times. So any change again is the level of consciousness, okay? With the vital signs, there's an ominous sign that we need to report. This one, Cushing's reflex, also called the Cushing's sign or Cushing's triad. Again, it's either called the Cushing's sign, Cushing's reflex, or Cushing's triad. What is the Cushing's triad? They are 1, bradycardia, 2, increased systolic blood pressure with wide pulse pressure, and the third is Cheyne-Stokes respirations. Okay, now let me clarify. Some authors, like this one, put the increased systolic blood pressure and the wide pulse pressure separately. Again, this author put the Cushing's triad as bradycardia, increased systolic blood pressure, or and wide pulse pressure. What is pulse pressure, by the way? The difference between the systolic and diastolic blood pressure. So give me an example of a high SBP with a very wide pulse pressure. Give me a blood pressure showing this. 200/80, something like that. Okay, so that's a wide pulse pressure. Okay, so because what's the normal pulse pressure? Well, 40, right? They say 120/80, that's 40 difference, correct? Okay, so that's the normal pulse pressure. When you have a really wide of 80 or more, that's a wide pulse pressure. Okay, so so what is the Cushing's triad? What is this? How is this significant? Well, it tells us that the patient, 1, has increased ICP, 2, they're probably gonna die soon. So do you want to see the Cushing's triad? When you see it, what does that mean? First, you see, yeah, I knew it. Patient has increased ICP. What's the other one? They're gonna die soon. All right. So when you see it, call the doctor, and then they'll call the family. That's an ominous sign. This is an ominous development. Patient's likely to die soon. All right. Nothing we can do. So this appears only in really critical patients. Okay, moderate to severe TBI. Now, in other authors, like I said, they put the SBP and the wide pulse pressure together. So they'll say bradycardia, increase as SBP with wide pulse pressure. And then the third sign is the Cheyne-Stokes respirations. What is Cheyne-Stokes respirations?
With the show.
Irregular pattern of apnea, hyperventilation, and hypoventilation. Really irregular breathing.
What is that called?
Cheyne-Stokes respirations, also called the death rattle, meaning they're gonna die. Okay. Okay, so since I don't know what textbook the NCLEX will refer to, so it's good to know the different authors say in the Cushing's triad. Okay, so it's either, but both all authors agree on bradycardia and systolic blood pressure with wide pulse pressure, but then the Cheyne-Stokes, other authors like this one didn't include it, but some authors include it in the triad. Did I make myself clear? Any clarification on that? All right. Temperature again. Why do we want the temperature to be no fever? What's the effect of fever on ICP? Okay, so this will increase ICP because of vasodilation, increased blood volume. Okay, so here's a warning again on fever. If we want to control fever. Let's go to changes in pupillary reaction now. Okay, so the size and equality of the pupils, you should assess. So if, let's say here, if the unilaterally dilated, meaning one pupil is dilated and then the other is responding differently, that means it's a hematoma. And then if both pupils become fixed and dilated, then that's acute injury to the upper brainstem and a bad sign. Okay. So can this be a good test question? Say the nurse sees both pupils fixed and dilated. The nurse knows this indicates A, B, C, or D. Right? Or I could say patient has a unilaterally dilated pupil. The nurse knows this is indicative of what? Right? A, B, C, D. Yeah. Very nice. I think it's in the here on your blueprint. There's pupillary changes here somewhere. Oh, it's under signs of increased ICP. All right. Okay. What's the goal again for blood sugar? Under 180. We talked about the halo sign, correct? Okay. I'll discuss the bowel and bladder, especially what they're talking about here, which is autonomic dysreflexia under spinal cord injury. All right, these some of these are repetitive already. We'll skip table 63-2. We're not testing this. This is for the doctor. Okay, as already mentioned earlier, so severe TBI patients die within 24 hours, 48 hours after admission. And that's been the trend, okay, more the rule rather than the exception. Do some patients survive? Yeah, of course, but not likely, okay? Severe head injury patients have very high mortality. So after the first few hours after admission, the doctors usually, especially if it's a young patient, they talk to the family about organ donation, because there's a lot they can do. Then they just outright tell them, "I would be honest with you, the prognosis is bad, and you may want to consider organ donation." Okay, and then whenever the patients say yes, and then the OPO people, live on New York, because they have offices in every hospital. They go speak to the family again right away, and then they see, they run blood tests, to see blood type, and then they start, I don't want to say selling it, but like going to potential recipients, okay, because they have a wide database already of people waiting. So they start sending the info already, so we can, because the moment the patients declared brain dead, and then they get the ball rolling. Okay, so start harvesting the organs. All right. So it's all about organ procurement at this point. Okay, so I mean, there's nothing we can do. Okay, like I said, it's more the rule rather than the exception. Okay, in severe head injuries, that's what's gonna happen. Okay, they're gonna die. Okay, we talked about cerebral perfusion pressure earlier. So what's the goal again? Okay, 70 to 110. I know the book says we want 50 or over, but do we want this around that? No. No, thank you. We want it higher, right? So these are all part of the secondary injuries. Edema, herniation, it's going to happen after the primary injury. It's going to be impaired oxygen and ventilation, because as the brainstem herniates, that's what's going to happen. Respiratory rate drops, CO2 levels rise, and vasodilation occurs, increased blood volume, and then increased ICP. This chart is similar to the bullets we saw this morning. Do they look familiar? What's the head of the bed elevation again? 30. Okay, and then alignment. What are other examples of Valsalva maneuver? Because remember, these patients are intubated and on a mechanical ventilator. So is it only having a bowel movement that is an example of Valsalva maneuver? What else are Valsalva maneuvers?
Sneezing.
Okay, so sneezing. What about vomiting? Yes. Okay, so be aware that Valsalva maneuver is not just the bowel movement. Okay. So temperature again, oxygen again, fluids again, maintain blood pressure. Okay. Since they are intubated and on a mechanical ventilator, are we going to suction?
Yeah.
We have to suction. What is the effect of suction? Is this Valsalva maneuver?
Oh,
Yes. Okay. So therefore, what is our rule again? Before we suction, what do we do?
100%.
Hyperoxygenate 100%. Okay. So there's a reason for everything, right? Especially in these patients, they have head injuries. We have no choice because they're intubated. We have to suction, but make sure you hyperoxygenate. So sedate. Okay. Again, if the doctor orders it, we want the patient to be in, if need be, they'll be in a coma. Okay. I know again, it's 60 to 70, but do you want 60? Okay. But technically, like I said, at 60, the brain cells are alive, okay? Technically, but again, are you satisfied with the 60? But exam purposes, what do you pick? Well, you actually technically 60 is good enough for the exam. Okay, but I mean, in real life, do you want 60? No, we want 70 or better. Okay, we already talked about the SIADH and the diabetes insipidus repeatedly, as this will occur again. So we started doing this in hemorrhagic stroke and now in TBI, same thing. Just to remind you of the hyponatremia that occurs in SIADH, remember there's delusional hyponatremia, correct? This will cause cerebral edema and therefore induce seizures. Are we clear? And what drug can be given again to decrease this? We talked about the drug earlier.
Which one, hyponatremia?
No, to decrease the edema.
No.
Mannitol. Okay. An alternative to mannitol, because let's say the patient's blood pressure is low. Can you give mannitol?
No.
What you can give instead is this, hypertonic saline. So this will still pull water out of the brain tissue and brain cells. However, what will it do to the blood pressure? It will increase it, okay? So instead of mannitol, we will give hypertonic saline. Give me an example of hypertonic saline.
10%.
That's too, there's no 10%, 3%, okay? 3% saline is the commonly ordered. 10% is, I mean, way too high, okay? So 3% is high, it's already high, or 0.225 also, but 3% is commonly used. So sugar, okay, between 80, 160. Again, don't forget to feed the patient. Seizures, we institute seizure precautions on all of these patients. It's expected. Okay. Because can we absolutely prevent seizures in these patients?
No.
No. So the ICP remains high. We know they're gonna have a seizure. So can we give something to prevent it?
Yeah.
They will be on infusions. Okay, so they can either get levetiracetam, for example, or phenytoin twice a day or 3 times a day. Okay, so they'll be on prophylaxis. And here's your summary. Let me just remind you about, because it's here, you look under the blueprint, something here that says about mild traumatic brain injury, about when they will be, what instructions you give. When you discharge somebody with a mild TBI. Yeah, to return when. Okay, remember that paragraph? Because that's your frequent teaching. So when your patients come in with mild TBI, all of them are sent home, but they need to know when to bring the patient back. You understand what I'm referring to? We had a paragraph listing those. Yeah, the slurred speech, the pupillary changes. Okay. Yeah. No, it's not just dizziness, but worsening. Yeah, because of course, they'll have dizziness at mild TBI and they have a headache, but it's going to be worsening. Okay. So if the symptoms improve or you have slurred speech now or the weakness or paralysis of one side, then that's that it's time to bring them back. Okay, that's it for. And then, of course, we manage the patient supportively also as part of the consequences when you have a patient with decreased mobility, right? Let me end with this part of because it's almost 12:30. This part of stroke, I forgot to mention. See here, it says Joint Commission core measures. Okay. There are 8 stroke core measures. What are core measures? So you know who the Joint Commission is, correct? Who are these guys? It's the man, right? They're the accrediting body that accredits all hospitals. So do hospitals want to earn Joint Commission accreditation? Yes, without it, then you lose money, right? Okay. So core measures are standards of care. So there's stroke core measures, there's heart failure core measures, there's diabetes core measures, one for COPD, cystic fibrosis, name a frequent pneumonia, name a frequently occurring diagnosis, and Joint Commission has a core measure for that, right? So therefore, every hospital has to prove that they meet the core measures.
Well, that's how it goes.
Yeah. So when Joint Commission comes in, accredits them, inspects them, so they go to the records. Okay, so not they don't just go around, looking at terrorizing nurses like, are you washing your hands? Okay, there's students there. Did they knock on the door? Okay, did you ID the patient? Not just that. Most of them go to the records. So they want to see that, okay, show me stroke. Where are your stroke patient records? And they won't ask you for one record. They'll go get them themselves. They'll just pick randomly. Okay, let me see this patient's file. Although that's old now because everything's in the EHR, right? So they just go sit in the Epic in front of a computer and then open a stroke patient's file. Okay, and then they'll see, did the patient receive the core measures? You understand? Okay, so let's talk about the core measures. 1, patient must be, let me just go to the source because it's not in your textbook, but I'm sure it'll be on the NFLEX. So let's just open a okay, here it is. One, two, three, four, five, six, 7, 8. Okay, here are the 8. So the 8 Joint Commission stroke core measures are 1. Every stroke patient must receive DVT prophylaxis, whether that's an anticoagulant or mechanical, for instance, that you put in, what sequential compression devices are? Oh, the leg straps that are attached to a machine that inflate and deflate.
Yeah.
Okay, so sequential compression devices or heparin, right? So whatever they use to prevent blood clots. 2, where they discharge on antithrombic therapy. What is antithrombic therapy? Aspirin and clopidogrel, okay, or antiplatelet. If the patient has AFib or aflutter, where they discharge on an anticoagulant. Okay, so who's on anticoagulant? Only if the patient has AFib or aflutter. Are we clear? So does every stroke patient discharge on anticoagulants? No, only those who have AFib and aflutter. So what type of stroke did they have? Thrombotic or embolic? Embolic stroke. Okay. 4th, thrombolytic therapy, if indicated. Okay, so meaning if they reach the hospital within how long again? 3 to 4.5 hours, did they receive thrombolytic therapy? 5, hospital day 2, meaning day 2 of admission. Did they receive antithrombic therapy? Meaning, did they receive aspirin and or Plavix or clopidogrel on day 2? Reason for this is on day 1, we don't give it because we need to hold, if they received alteplase, we should not be giving aspirin or clopidogrel within 24 hours. That will increase the chances of bleeding, right? I mean, don't worry, they're covered by the thrombolytic, okay? The thrombolytic dissolved all the clots. Okay, so this is consistent. So we don't give aspirin or clopidogrel if they receive alteplase today. So we hold it for 24 hours. So is this consistent with that therapy? Yes, we evaluate antithrombotic therapy on hospital day 2. Because when did they receive the thrombolytic? Day 1 or day 2? Day 1. Okay. 6. Did you discharge them on a statin medication? What is a statin and why is it given? Because why? Why are they put on statin? What was the root cause of all this? Atherosclerosis. Okay, so this is how they got the stroke in the first place. So they had diabetes, hypertension, high cholesterol, obese, name it. Okay, metabolic syndrome, that just smoking, that's what caused the atherosclerosis. So every stroke patient must be on a statin medications. Did they receive stroke education? Now they even qualify this. So they'll check the patient's primary language and then see what stroke education packet did you give them? The Spanish, they're Polish. Did they receive the information in their language? All right. Especially in New York City. I mean, we expect everyone to be, different language, right? So therefore, it must be available in every language. The education packets. And then last, did you assess them for rehab? Now, it just says, did you assess them for rehab? Not that the patient went to rehab, okay? Because not all patients will go to rehab because do they all look the same when they leave the hospital? No, some go out walking, some go out on a stretcher, some go out on a wheelchair. Okay, so we don't know how bad the stroke was. But the important thing is where they assessed for rehab. So it has to be documented somewhere, right? That the PT saw them and then there was PT notes, complete PT notes. What is the PT's recommendation? Blah, blah, blah. All right. Any question on the 8 core measures? Okay, so I
do ask this question,
yeah, just select all that apply.
Oh, yeah, okay.
Yeah.